Silberman, who is Tufts Professor of Psychiatry, and he's currently President of the Tufts Medical Staff. He has a BA from Yale, his MD from Tufts, psychiatry residency at Mass Mental Health Center, and further postdoc psychiatric training at Harvard. Then, both at Washington, D.C. and Philadelphia Psychoanalytic Institutes. He is a member of 6 editorial boards, has a bibliography which includes over 50 refereed articles, 15 book chapters, and 3 books. Honors and awards are extensive, including a large number for outstanding teaching, especially from residents, who would know better. He's been an invited speaker worldwide, and if that is not enough, he's with us today to address PTSD. Neither he nor we have disclosures. Please welcome Dr. Silberman.
Thanks for that introduction. Gee, I'd like to meet that person sometime. Sounds terrific. I don't really recognize him though. So what I want to try to do is give you, as the slide says, an overview of this condition. And although I've dealt with this for many, many years in my career, my professional activity, I don't think I really appreciated the extent of it until I started maybe, 10 or 12 years ago to do occasional assessments for the Massachusetts Public Employees Retirement Commission. And these were overwhelmingly people who held public jobs. It could have been police, firefighters, EMTs, or school teachers in schools for special needs kids, sometimes hospital employees in state hospitals, that sort of thing. And almost all of them had traumatic stress disorders of some kind or another. And I really don't think until I had seen a dozen or so of these people, and I'm not sure how many I've seen now, but quite a number, I don't think I appreciated really what trauma can do to susceptible people and what the range of susceptibility is among people. So what I want to do is give you a sense of the epidemiology and the phenomenology of it, some of the medical consequences and connections, and a little bit about treatment. And I don't have anything to disclose. Okay, so PTSD is one of only 2 conditions in psychiatry diagnosis that I can think of where there is a precipitating event as part of the diagnosis. And so you have trauma, and then in the wake of the trauma, for people who do develop this disorder, you have a cluster of this kind of thing. A lot of it centers around anxiety, of course, and PTSD, I think, at one point was actually classified as an anxiety disorder, but but kind of preoccupation with the traumatic event or events. Sometimes it's literally re-experiencing of it, but at least preoccupation. Hyperarousal, and we'll talk about how that manifests. A lot of avoidance. Sometimes people feel very numb, but inevitably they avoid anything that reminds them of the trauma. And people's view of themselves, of life, of the future becomes very negatively skewed. So what is trauma? Now, this is an interesting issue because the way trauma is officially defined, it's got to be something very severe. So that you have to either have experienced or been personally a victim of something where there's a threat of serious harm, death, or some horrific scene of injury, dismemberment, and you felt intensely afraid at the time. However, what you see in real life is that there is an enormous range of events that can cause some degree of these symptoms. And of course, as with every other disease, not everybody who has this condition is equally ill. So that varies too. But sometimes people develop traumatic stress symptoms in response to things that simply do not meet the criteria of trauma that I just showed you. I was just talking about this study, that now of course I can remember who did it, a psychiatrist in California named Lenore Terr, who followed up a bunch of kids who had watched the Challenger disaster on TV. That's it. They watched it on TV. They were not in any way threatened. These were not people who were related to any of the people who died in this. And she followed them for a number of years and found that they were symptomatic. They may be not highly ill, but they were symptomatic. I don't know if any of you have ever had traumatic events that, of some degree or another, that left you feeling not quite yourself. I can tell you about one in my own life. I have an old house that we spent many years renovating, and at one point I was using some paint stripper that turned out to be highly flammable, and in a very freakish way a spark ignited the film of this stuff on cabinets in our pantry, and all of a sudden the whole wall of cabinets was engulfed in flames, and I didn't know whether my house was going to burn down. And I can tell you that for a number of years I just simply didn't talk about it. There was avoidance. It didn't feel right. I didn't talk about it. And so it doesn't necessarily take much. I didn't become ill. I didn't have PTSD, but I noticed that there was something in me that I felt really bad about that happening, being out of control, and I had sort of mild degree of what everybody goes through. Oh God, what did I do wrong to have this happen? And I could have burned down my house. Turned out to be actually pretty minor. But so the Challenger disaster, I evaluated a woman a number of years ago who had a prolonged divorce and custody battle. And she really had a traumatic stress disorder. She had some risk factors, to be sure, but I really wouldn't have thought somebody could get a traumatic stress disorder that looked for all the world like people who have suffered a classic trauma. Maybe not the world's most severe case, but she was substantially impaired. And I evaluated a woman who had an administrative, punitive action at work. Very unpleasant. None of us would have wanted to have it happen, but she wasn't claiming that anybody threatened her physically. She was never in any danger. She felt it was terribly unfair, but she also developed a traumatic stress disorder, so that you can have really in susceptible people a very wide range of things that can leave the person substantially symptomatic. Here are some of the details. Re-experiencing, it can take the form of intrusive recollections, often does. Nightmares, very, very common. The flashbacks, that's of course what became famous in the Vietnam veterans. It's a kind of dissociative symptom where suddenly you lose track of your actual surroundings and you are replaying in a very realistic way in your mind some scene of danger or trauma. Anything that triggers a memory of this gives you a lot of anxiety and distress. I have have been treating for a number of years a Boston police officer who was at ground zero at the Marathon bombing. And he talks about this all the time and the need to avoid, on Marathon Day, he goes out of town. He literally goes out of town, and he can't watch anything on TV that reminds him of those events. Increased arousal. These people have very disturbed sleep. They're typically very, very irritable. It causes enormous stress within their families. They're vigilant. They will tell you when they go out on the street, they're looking around all the time to see who's there and is it possible that somebody dangerous is in the vicinity. And the interesting thing about this is that the original trauma doesn't have to be something like that. It doesn't have to be that you got mugged, for example. You get this kind of reaction as a very general reaction to having been in this dangerous or threatening situation, whatever it happened to be. Some people will tell you, a lot of people will tell you they can't be in crowds. They simply can't be in crowds because it feels too risky. They have a big startle response, and they have a tremendous amount of difficulty concentrating. Avoidance. And I don't have to belabor this list, but they typically tell you, and again, this is something that doesn't have any direct response or connection to the trauma. A classic, typical story is, I used to be an outgoing social person, and now I sit at home. And, maybe I talk to some friends on the telephone. Maybe they come over once in a while. I don't see people anymore. I avoid parties. I avoid family. I've heard that. I cannot tell you from how many people. And they have a sense of diminished expectations, foreshortened life. They lose interest in many things. And they're often very fuzzy on the details of the traumatic events. And one form of treatment, which I'll get to later, actually aims at helping people to get clearer in their minds what actually happened to them, because these things are often remembered with lots of distortion. More about the same. People tend to feel guilty. In my little minor example of the fire, I really did. And about every aspect of it, I ruminated about it a little bit. Like, for example, I could probably have put it out right away because I was thinking of it as an electrical fire. It wasn't an electrical fire. It got caused by a spark of a little bit of steel wool that had fallen into an electric socket and sparked, but it was actually a chemical fire. And so I was beating on it with a dry towel. If I had beat on it with a wet towel, that would have been the end of it. Well, I spent a lot of time thinking about that and thinking about, I should have known that this could have happened. This is absolutely typical, no matter what the trauma is. Certainly, women who've been victims of rape, it's absolutely classic. What did I do wrong? Did I do something to invite this? Did I do something to make this happen? Whatever it is, this is very, very classic. And people really withdraw from their lives. That's the thing that I think impressed me in all those evaluations more than anything else. How people's entire lives disappeared and diminished and contracted. And they're all telling me the same story. I don't go out much anymore. Maybe I do some work in my backyard. Maybe I'll walk the dog. early in the morning when there aren't too many people around. But it just pervasively eats away at people's lives. Many people who have had particularly disastrous traumatic events, and this is often true of, for example, people who have been abused as children. And it's not just a one-shot disaster. It's something that was going on for years, perhaps either physical abuse, sexual abuse, often by somebody in the family, and the other members of the family, the other adults, didn't protect them, often denied or even punished the child who tries to report it. You get a complicated picture that includes the things on this list. Affective dysregulation. These people are, they're irritable. Their mood is up and down. They have intense bursts of emotional reaction. They're impulsive. Dissociation, of course, it's a sort of technical word. What it means is the tendency of the brain, the mind, to wall off some aspect of experience from other thoughts and feelings. So the flashback is the most famous and dramatic example of that all of a sudden you're not aware of your immediate surroundings. But then there's some common things that are often present in garden variety anxiety. Depersonalization is a state where you feel like you're not quite real, or derealization, you feel as though things around you are not quite real. And people commonly have things like that. Lots of somatization. Headaches, stomach aches, aches and pains of all kinds. Very common. And of course, self-destructive behaviors, increased risk for suicide. Probably one of the most common kinds of self-destructive behaviors is self-cutting, which inevitably the people who do it report as not a suicidal behavior, but in a very odd way, an attempt at self-soothing. They say they feel relief of tension when they cut, and there's a whole theory that perhaps what these people are doing is stimulating release of endorphins. But it's a wide range of self-destructive behaviors, including, substance abuse that's self-destructive, self-destructive relationships. People who have been abused as kids tend to get into abusive relationships as adults, and preoccupation with the events, with the perpetrator. People's mental life may center around this. So here's a study looking at medical manifestations. So this is a form of somatization. So these are the odds ratios of people with PTSD turning up with this list of symptoms compared to the general population. And you can see that having PTSD puts you at a 2 to 3 times greater risk for having these things among others. These are just the things that were looked at in this study, and these things were adjusted for covariates that would be likely to confound the likelihood of somebody having these kinds of symptoms. So this is a little bit of an overview of different types of trauma and the rates of PTSD in these various kinds of trauma. And what you see is that, in a certain sense, the more personal the aggression is, the more likely you are to become symptomatic. So a natural disaster has a much lower risk than a sexual assault. If it's just something that happened, it has different meaning to people than if you were personally assaulted and singled out. And rape is also the only one of these things where men are more likely than women to develop this condition. Also, being ill and having medical procedures carries some risk for development of a traumatic stress disorder in some people. This is a fairly recent study. 12% people who have had MI or unstable angina, ICU survivors, seems high, but I don't know. I don't see those people. And stroke survivors, in this study, up to 25% developed traumatic stress symptoms. I recently evaluated a young man who had run into unexpected difficulties in starting a new job. He needed certain credentials that he was not from the state, licensure credentials that he was not able to get, and he became extremely anxious and developed and really, had to take a leave from work, and he went into therapy, and it turned out that he had had a medical procedure, some kind of a heart procedure as a kid, and apparently the anesthesia was not quite adequate so that he didn't know anything and didn't feel anything, and he had memories that he had more or less ignored of being in the operating room, being in this frightening and somewhat painful situation and remembering it. And it turned out that the current events had stirred up feelings related to that experience. And it was, the two seem very disparate, but it just is a good example of how being in a situation where you feel out of control, in this case threatened not physically, but threatened with a career setback, connected in his mind to an earlier situation where he had felt out of control and in physical danger. So this happens, and it's well for us to be aware of it. Now this is another version of the table. This is not based on the trauma and how many people develop PTSD, but based on a cohort of people who have PTSD and what was the trauma? Where did the trauma come from? And you see the same thing. About a third, the biggest chunk, were victims of sexual violence, and then loss, physical violence. Organized violence really means combat violence. Or you were in a war zone, for example, and you suffered the consequences of war even if you were not a combatant. And other things, motor vehicle accidents, natural disasters. So again, it's a wide range, but the worst ones are the ones with special personal meaning for the person. Now if you look at this slide, you see that a shockingly large number of people in this epidemiological study were exposed to trauma at some point over the course of their lives. But only, in this study, it's usually quoted in this range, 6 to 9, 5 to 10% have a lifetime prevalence of PTSD, and only 8 to 12% develop PTSD after such a trauma, so that the individual susceptibility factors play a huge role. So what do we know about the risk factors? Well, we know, as you saw in the slide, women are more susceptible than men, and of course that's true in psychiatric epidemiology in general. The vast majority of the diseases, women are at greater risk. Lower educational level, being single, certainly the amount of support that you have is enormously important. The police officer that I mentioned earlier was really at one end of the spectrum because he had a loving, supportive family, Also, the Boston Police Department is pretty enlightened about consequences of trauma. I've assessed a number of police officers from smaller towns, not necessarily tiny, for example, Springfield. And what I'm told by those people is if something traumatic happens to you, you suck it up, you don't talk about it, and the general culture is that a group of the guys go out after work and drink and maybe tell war stories, but you sure don't show any signs of vulnerability. In Boston, that's absolutely not true. They have what they call the stress unit. They pay a lot of attention to it. This guy got a lot of outreach from the police department. He's now on a disability retirement. And so he had about as good a support situation as you can have, and although he has been significantly symptomatic, he's recovering. And how many years ago was the marathon now? Was it 4 years? 5 years? But it's taken that long, but he's better. He's now better. Prior trauma, absolutely a risk factor. And interestingly enough, that's true of head trauma too. If you have mild head trauma, a risk factor for being significantly symptomatic is prior head trauma. So there's something very general about this that happens in the brain. Childhood adversity, any history of personal or family psychiatric illness, so diagnoses of things in the family are a risk factor. Many other things, however, the meaning of the trauma, and you sort of saw that in the list of more versus less personal things, but for example, in World War II, we didn't hear nearly as much about soldiers having PTSD and coming home and having PTSD after they've come home. And one of the main reasons for it is that there was really good consensus about the necessity of going to war in World War II. And these people came home as heroes. My own father-in-law was a good example of that. He was in the D-Day landing. He was in the Battle of the Bulge. He was in the thick of it in Europe and pretty heavily decorated. Was a hero to his family, his community. Still didn't talk about it. My wife says he did not talk about it until he was in his 70s. Nobody could ever get him to talk about his war experiences. So anyway, in Vietnam, however, it was a different story. There was not nearly as much consensus about the necessity of being there, the goals. The soldiers came home and they were viewed often skeptically as potential, are they drug addicts? Are they heroin addicts now? The My Lai massacre, are these guys who have been massacring women and children over there in Vietnam? And that was the start of the VA system waking up to this as a huge public health problem. So the meaning, and it's well known among military personnel that unit morale makes a huge difference about whether people are going to develop these conditions or they're not. Level of support, acceptance versus stigma, I just mentioned, and various personal characteristics. So in some of the things that are in the literature, this quality called locus of control. Some people have a tendency to attribute control to things outside themselves, and some have a tendency to see themselves as being in control of what happens to them. And there are some standardized tests of this that have been developed by psychologists. And the people who have a tendency to feel less agency and less power in their own lives, that's a risk factor for developing PTSD. Startle threshold. This is a fascinating study that was done in California on police recruits. So these are people who had had no trauma in their lives, but they were going into a profession in which there would be a high risk for trauma. And one of the things, so the idea was to study these people and try to be clever about looking at the right factors and then seeing what was predictive about who would eventually develop traumatic stress disorders when they were out there on the streets and their lives were in danger. And one of the things that came out most strongly was startle response to loud noises. Now, these are not people who had ever been traumatized by any kind of a bomb or shelling or gunfire. This turned out to be an innate characteristic that the people who had bigger startle responses just naturally, just the way they're wired, they were more anxious people. This turned out to be a risk factor. General coping capacity, things like intelligence. It's more intelligent people have better prognoses for practically everything. And so all kinds of general things, some of which have been well studied, some of which have been less well studied. Here's an example relevant to this community. In this study from 2005, in a population of Cambodian refugees, 62% were found to have PTSD 20 years after immigrating to the U.S. So, I mean, and you know, we all know something about what went on in Cambodia with mass killings for no particular reason. And these things have a very, very long tail and a very, very long persistence. And if you think about the situation as a whole, it's mass killings, yes, but it's also loss of a support network, loss of family members, loss of your country, your way of life, moving to a new place where you're a minority, you don't speak the language, you're at the bottom of the heap in terms of education and opportunity. It's all traumatic, and it's all likely to perpetuate your symptoms. Speaking of which, course of illness. So in this study, 25% are still symptomatic after 6 months. 66% have not recovered at a year, and a third are still symptomatic after 10 years. That's the scary thing about this. It really can hang on. When people have a bad case of it, it really hangs on, and it has downstream consequences. So for example, in these people that I have evaluated for disability evaluations, disability retirement, one of the things that I've heard over and over again is that they couldn't work, so they needed an income, so they put in for disability. But once they were getting disability, and at the point where I saw them, it was generally, maybe it had been workman's comp, but they were out of their job, they actually started to feel worse, not better, because they had no structure, they had nothing to bring them out of their house, and they felt a huge loss of identity. You know, time after time, I would hear somebody say, I loved being a cop. It's all I ever wanted to do. I loved the job. Now I'm nobody. Now I'm nothing. And so it feeds on itself. And the losses mount up because the symptoms are such as to separate the person from other people. And even if they have a spouse, very often it's because of that list of symptoms and the withdrawal and the numbing and the irritability, it disrupts the relationship with the spouse, and not a few of them lose that relationship too. So it just is a thing that unless there's some kind of effective intervention, it feeds on itself. So here's a list of some of the things that have been found biologically as concomitants of PTSD. And this is very much a work in progress, and we don't know, for example, for sure how many of these things might have been not in the normal range premorbidly, because of course nobody had any reason to measure your hippocampal size before you had PTSD. But certainly these people, when you look into various things, I mean, the classic thing is that the HPA axis gets burned out. That with depression, it's a state. It tends to be a state of hypercortisolemia, and traumatic stress disorders tend to be a state of hypocortisolemia. That's been a signature finding for many years. But these other things too, and of course adrenergically increased. We'll talk about the treatment, but one of the classes of medications that is often very useful is these adrenergic agents, like blood pressure medicine, which addresses the increased noradrenergic levels. Now, this is a screening tool meant for use in primary care. And if anybody would like a copy, I made up a bunch of copies, which I can just leave on the desk for anybody who'd like. But it's just a very quick, simple tool which first screens for a possible traumatic event, and then for some of the major symptoms that you've been seeing on these lists. And if people say yes to very many of these things, you might think about talking to them about a referral for treatment. And of course, although it doesn't say this here, if you're getting yeses, then of course the next question needs to be, have you ever had thoughts about killing yourself or wanting to end your life? Treatment. So here I am talking to a group of non-psychiatric physicians, and yet I have to say that for the most part, PTSD is not something that should be treated in a primary care setting. It's hard enough for psychiatrists and other mental health professionals to treat this syndrome. It's complex, it's difficult, it is usually, there's no quick fix, it's multimodal treatment. One size does not fit all. Even in terms of medication response, people differ in what works well for them. Medications generally relieve symptoms to some degree, but they certainly don't take care of the whole thing. A good example of a sort of a partial and unusual response, again, is this police officer. So there's a general idea in treating PTSD that benzodiazepines are not so good or don't work well or lead to difficulties of some kind. That's a whole other topic that I will restrain myself from getting into because I think it's vastly overblown. But this particular guy did not respond to the first-line medications that we use for PTSD. He did not respond to a serotonergic antidepressant. He did not respond to prazosin. The only thing that's actually helped him is Valium, and I wouldn't have predicted that. But I've tried many different things because I kept thinking, and partly because he had many symptoms that were not covered by this. So what did the Valium do? It took the edge off his anxiety. It took the edge off his startle response. It helped him to get through his day a little more comfortably, and it improved his sleep. What didn't it do? It did very little for his response, for example, to loud noise. He would absolutely have that. It didn't do anything for his avoidance. Didn't do anything for his irritability. He has a wife of many decades whom he clearly adores, and he has had great trouble keeping himself from snapping at her. And so I kept looking for other things. Nightmares, plus minus, have not really been his biggest problem, maybe more so right at the beginning. So, in terms of just the medications, this is a pretty good list of target symptoms that the medications may address. And again, different medicines work differently in different people, and they work to greater or less degree in different people. Now you notice what's not on that list. What's not on that list is people's tendency to self-blame, to guilt, to pessimistic view of life, to sense of worthlessness, much less susceptible, and often self-destructive behaviors, not necessarily on the list, although they may improve. Medication types, so the stars indicate in a very rough way the strength of the evidence for effectiveness of these various things. So probably the most accepted drugs for this condition are the SSRIs, and They can do a variety of things. They certainly can improve mood. They may have some anti-anxiety effects. They have some benefit for intrusive thoughts, and in some studies they have some benefit for avoidant behavior. So in the people for whom they work, and that's not everybody, there can be a wide range of things. Similarly, the SNRIs, medications like venlafaxine or duloxetine, one can say the same thing. There's a little less evidence about them. Second generation antipsychotics, I don't love using neuroleptic medications for people who aren't psychotic, but sometimes they're really quite helpful. They often have very good anti-anxiety effects, and they may also help with things like impulsivity, especially impulsive aggression. Prazosin, which is a presynaptic adrenergic agonist, and so it decreases throughput of noradrenergic tracts. There's a little bit of a mystery about prazosin. It was found to be very, very beneficial in decreasing or eliminating nightmares and improving sleep. And there's also some evidence that it can help with daytime anxiety and daytime tendency to re-experience, to have flashbacks, preoccupations. There was a huge VA study in which they were administering this medication in up to 25 milligrams a day in divided doses. And it was very, very positive. And my personal experience with it has been that it's helpful in the vast majority of people for whom I've ever prescribed it. Again, not this policeman. A police officer just felt kind of draggy on it and didn't feel like it was improving his state of mind much. But then subsequent studies didn't all confirm this. So it's a little bit of a question mark, but I think it certainly is a medication that should be on the list. And of course, it also has an advantage of acceptability. When you tell people it's a blood pressure medication, they don't associate it so much with, being, quote, crazy or, having a psychiatric disorder. Anticonvulsant mood stabilizers have a general tendency to level out intense emotions. Gabapentin is often very good for that, and to decrease impulsive behaviors, although again not as well studied. And then benzodiazepines, in some people they're really quite helpful. And without getting way off into this, I will just say that benzodiazepines, and there's a vast literature now largely ignored, that tells us that benzodiazepines in the general public have actually very low abuse liability, that the people who abuse benzos are polysubstance abusers. And of course we know opiate addicts. It's endemic, but that's a different population. Anyway, not among the more favored drugs for this, but should be somewhere on the list. Psychotherapy of various kinds, enormously helpful. And here's a list of things that may be addressed in psychotherapy. People almost inevitably need psychotherapy of some kind in addition to medication. More goals. It's a long list. And a wide variety of psychotherapies has been proposed. Without going into all of them. Some of them are. See, is there another slide? No. Okay. Some of them are more behavioral than others. There are, for example, therapies that don't do anything other than attempting to help the person learn self-soothing techniques, what to do when you get all these symptoms and feelings. Then there are ones that are aimed to desensitize you in one way or another to the traumatic memories and feelings. Then there are ones that are aimed to help you deal better interpersonally with the people that you're trying to be with and interact with in your life. And then there are ones that attempt to help you sort out what happened, because there's almost always some distortion and confusion, and there's a group of people that can benefit by getting clearer what actually happened. No, there really wasn't anything I could do about it. I really was helpless in the face of this, and it doesn't make any sense to blame myself. So again, depending on the personality, the strengths, the limitations, and the motivation of the individual person, some combination of these medications and these therapies often is very helpful. But it's a long road. And the one thing that I would also mention just at the end is that sometimes this is a condition that waxes and wanes, so that sometimes it appears to disappear, sometimes for decades, then something in the person's life triggers it, and it comes back after having been gone for a long time. So this is something that tends to really change your brain in some very long-term way. There is long-term learning that we try to help people unlearn, but we really don't get rid of it completely. So that's what I had prepared to say, and I'd be happy to have any kind of discussion that anybody would like to have.